Hello, my name is Allison Hopkins, and my presentation is on adolescent suicides in rural areas. And the case study that I used was titled Suicide Rates Climb in U.S., especially among adolescent girls. And through this, I will be acting as the role of public educator. My problem statement will address who, what, when, where, and why. And my problem statement says adolescents living in rural areas have a greater risk of depression, increasing the chances of suicide due to lack of resources in public health areas. So the description of the issue, which I'm going to be going over, we're going to go over the social ecological model. So this is the definition, and this is the model in which we're going to use. So the first, inner layer is the individual level, and we're going to look at the things that I decided to focus on within this level is education, knowledge, beliefs around mental illness in relation to rural areas. Through the research, I looked at to really look at this case study and develop some training, some programs, and some solutions to the issue was the fact that in rural areas there is a negative stigma around mental illness, and a lot of people don't feel that they don't want to be classified as mentally ill, and so in rural areas it's especially increased, and a lot of people don't have the education in these areas to know anything about mental illness. There's also the interpersonal level, which is the next level out. Peers influence their peers, which is the greatest part with, teens. So teens tend to really listen to their friends. And so this can be positive or negative. If they have teens that they rely on that have positive behaviors, such as studying or not staying up late or not giving into peer pressure with drugs and alcohol, that tends to be a positive experience. They tend to trust those people. If they give in to peer pressure in the way of drugs, alcohol, this can also be a negative thing. We also look in the interpersonal relationships between family members. Family members can be positive and negative. If you're dealing with family members that are abusive, they have their own mental illness. Sometimes it's not so easy to go to those people. Also, teens tend to feel more burdensome towards family members, especially if they are afraid of the response of their family members if they're not super supportive. So those are the two different interpersonal relationships that happen with this health concern. The next ones is the organizational level, the community level, and the policy level. So the organizational level, the school plays a huge role. Teens and adolescents spend most of their time in school with staff members, faculty members. So in this level, it's really important for the staff and faculty to gain and have access to trainings, resources, and extra support around the community. And this tends to be less in rural areas. Community level funding and support within the school and caregivers in relation to teen suicide is sometimes is minimal in rural areas. There's not a lot of close relationships between partnerships, even though that there should be more funding and opportunities in this area. And support within rural areas because of the lack of access to healthcare systems and other support systems around teen suicide and programs that help this issue. And then the policy level is the last level that we're going to look at, and that's adapting already made school policies and adding ways to help the teen suicide and depression rate. So that could also mean adapting the policy to incorporate trainings to faculty on how to address teen suicide. So proposed intervention, I did 3 different steps. Step 1 is trainings. Step 2 is screenings, and step 3 is prevention, implementation of resources and programs. So with step 1 in trainings, rural areas again have less access to healthcare and mental health care. Everything's a little bit more spread out, not enough transportation. And so to be able to start this program and interventions, we want to narrow down the field. So, with percentage wise, it tends to be higher. Free and reduced lunch rates in rural areas tend to be higher because poverty tends to be a little bit higher in these regions. So these are the children that have more access to, federal programs that are funded, and that have less access to a lot of programs that could actually help them. So trainings are extremely important, and these trainings are called gatekeeper trainings, and faculty and staff members and possibly teens from Big Brothers, Big Sisters could be trained into helping to support students that may be depressed, being able to identify students that may be depressed, or, possibly having suicidal tendencies. So they could be trained yearly to be able to identify these students. Screenings, implementing depressing screenings, which are already kind of made, which a lot of facilities, especially PCPs, will use brief questionnaires about depression, which leads into the suicide part of that. That's one of the questions. So this is already made, not to create the wheel. So this could also be used in these areas, which we've already identified in the first step of free and reduced lunch rate schools in rural areas. So 75% of the students, they would participate in this study at first. And that's the goal that we would do. And it would be anonymous, and we could just really see the percentage of kids that possibly are depressed in those areas, what they suffer with, if they have any suicidal tendencies, and how to address those issues. Step 3, prevention and implementation of resources and programming. Again, this would be following the training and then also adapt it into already made policies within the school and institutions. So strengthening those programs with, constant resources and access into communities and also within the schools can also help the prevention of teen depression and suicide. So with the trainings, the screenings, and the programs being put in schools can really help this issue. So the proposed evaluations that go with this is also in a 3-step. I broke it down into 3 steps. So within the trainings, surveys will be given to trainees during the training sessions, which would happen once a year. There's a pre and post survey, once at the beginning of the year, one at the end of the year, if they follow, the training evaluation system throughout the year. And these are both surveys. It's very short, very to the point, but then also they can give the feedback so they have some sort of feeling that they are contributing, that they have ownership of this program, and that they have some say of how this will go down in the school system, which is extremely important. We want to make it easy to administer, and hopefully this will become a longitudinal study, so we can see the outcomes within the trainings and within the schools, and follow them throughout the years to see if there's an improvement, which can also find funding in the long run. Screenings, like I said before, there's the screenings that will help students, figure out, it's a brief questionnaire that teachers can give out to students, school counselors, nursing principals, anyone that's, that they feel is an at-risk after taking the training can really take this brief survey that they can go over and really, sense and give the student and their caregivers the right support. And then there's the prevention implementation resource program. So, anything to deal with partnerships around the community that could really help this situation with schools, such like I brought up the Big Brothers, Big Sisters, be able to make those connections. Also, any resources within the community in which, other community members can give trainings to parents or anything like that. Those all need to be implemented within schools and community settings so that, at least all the word is getting out about, minimizing the stigma of mental illness and how to help the issue of teen suicide. So there are potential barriers and challenges with any program development. For this particular program, we are looking at adolescent suicide and depressions in rural areas. So some of the barriers and challenges that we might run into is school not wanting to take part in the program. This might trainings and screenings and questionnaires might take too much time, not enough funding to help fund this program or trainings. And then also, if there's any policy changes, books might have to be changed, handbooks might have to be changed. Community school hesitance to stigma around mental health. A lot of public schools do not want that stigma related to their school, and parents getting defensive about their parenting skills. Through the logic model described here, it's gonna, I'm gonna try to go this very quickly and thoroughly, but we're gonna go through the different resources that we can use here and how they can affect. So as you can read here, so we have schools, and this is how they can affect. These are the activities that they can help address. Homes. And lastly, local businesses. So moving to the right, these are the activities. So if these activities are put into place, then these are the outcomes of the activities. And moving right along, the outcomes can also be, we're going to say, if and then statements. So lastly, I will talk these through. It will go from the left to right, and we're going to talk about the short-term goals, which is in the yellow, and the last, which is in the brownish orangey kind of color, which is the long-term goals. So if teens will ask for help when needed, this is what will happen. Then these things will happen within the community. If schools will become involved with screening, trainings, and adapting policies, then this will happen. If less stigma around mental health, if there's action as a preventative response to teen depression and suicide, if there's a response to preventative measures, then this will happen. These are the short term. Now, with these short-term goals, if these short-term goals are happen within the community, then these long-term goals will happen. So this is basically the logic model of how everything will happen. So we move from the resources within the community and get those closer relationships, and then move to the activities that will happen, moving out to the outcomes of those activities, and then moving to the right, we have the short-term goals, and then the long-term goals within the community dealing with adolescent suicide and depression. So this is the end result, moving from left to right.